Good afternoon, everybody. My name is Patrick van Renen and I'm a pediatric gastroenterologist at the University Medical Center in Groningen in the Netherlands. And this is the Dutch referral hospital for pediatric liver diseases. In this presentation, I will demonstrate a stepwise approach for investigating children with IBD and liver test abnormalities. Liver injury is usually insidious in onset. By the time that symptoms have appeared, the damage may be well advanced. It is therefore important to investigate this clinical problem in an appropriate and timely manner. In the coming 20 minutes, I will use David here as an example. He is 15 years old with colonic Crohn's disease, and today he is at the infusion center for his 5th infliximab infusion. He responded favorably to infliximab and azathioprine with normalization of fecal calprotectin and C-reactive protein and absence of symptoms achieved between the 3rd and 4th infusion. The pre-infusion check did not reveal any abnormalities, especially no fever or skin rash. Peripheral blood analysis showed normal CRP, gamma-GT and total serum bilirubin. But the ALT was elevated. That is the reason that the nurse at the infusion center now asks you whether she can start the infliximab infusion. What would you advise? A basic panel of liver tests in children should include ALT, gamma-GT, bilirubin, both total and direct, together with tests of synthetic function including albumin and PT. PT better reflects the actual synthetic function than albumin, since it may already be prolonged within 24 hours after significant liver injury. As the reagents to perform the prothrombin test vary between laboratories, PT is better expressed as an international normalized ratio to standardize results across different laboratories. This slide is the most important one of my presentation. Grading the severity of liver test elevations into mild, moderate and marked is central to the timing of diagnostic actions. Please note the upper limits of normal. Establishing normal ranges in the pediatric population has been challenging due to the differences in the definition of healthy controls and interlaboratory variability. Recent publications that included thousands of healthy children and adolescents showed that the true upper limits of normal are significantly lower than previously thought. The classification shown here is based on the National Cancer Institute's grading system and is useful for signal detection, although the cutoffs are somewhat arbitrary. Retesting liver biochemistry is necessary to evaluate whether the liver injury is progressing or regressing. In the context of a child with IBD who has no symptoms referable to liver disease and who has mild liver test elevations, it is reasonable to retest after 1 month. Moderate to marked elevations, such as in David, mild abnormalities that persist after 1 month, or mild elevations with clinical symptoms require immediate investigations of the etiology. The first abnormal liver test is generally the basis for establishing the liver injury type. The ratio between ALT and gamma-GT can help recognizing the pattern and may point towards a different set of differential diagnoses. A hepatocellular profile is characterized by a disproportionate elevation of ALT compared with gamma-GT. Common causes include autoimmune hepatitis, viral hepatitis, and non-alcoholic fatty liver disease. In the absence of positive clues for these disorders, an evaluation for Wilson's disease and alpha-1 antitrypsin deficiency is warranted. A cholestatic profile is a disproportionate elevation of gamma-GT compared with ALT. Common causes include primary sclerosing cholangitis and bile stones. Autoimmune sclerosing cholangitis, also called overlap syndrome, typically has a mixed pattern. Drug-induced liver injury can present with a hepatocellular, cholestatic, or mixed pattern. Most drugs used for treatment of IBD have the potential to cause liver injury. Attributing abnormal liver tests to any of these drugs requires systematic evaluation. This table shows that each IBD drug causes its own typical liver injury, also known as signature. Differences in drug signatures are most strikingly related to differences in latency, that is, time to liver test abnormality after the implicated drug has been started, and biochemical injury pattern. Thiopurines have two different signatures. In the first place, it can cause temporary mild elevations of ALT and gamma-GT. These occur shortly after starting therapy with thiopurines. Although this type of liver test abnormalities usually resolve spontaneously without dose adjustments, it is advisable to evaluate thiopurine metabolites. I will come back to this at a later stage in this presentation. The second signature of thiopurine is more serious. This liver injury starts as cholestatic hepatitis, but sometimes progresses to the vanishing bile duct syndrome, with a complete loss of intrahepatic bile ducts. Long-standing use of methotrexate can cause accumulation of fat into the liver. This is usually asymptomatic and therefore mostly found by coincidence. It can progress to fibrosis and cirrhosis. Concurrent supplementation with folic acid may lower rates of abnormal liver biochemistries. Anti-TNF, infliximab in particular, sometimes causes an immune-mediated hepatitis that bears a lot of similarities with autoimmune hepatitis. It responds well to corticosteroid treatment and rarely relapses after steroid discontinuation. Now let's go back to our patient David. The nurse is still waiting for your answer. What is the biochemical pattern here? Yes, it's hepatocellular. David is on azathioprine and infliximab maintenance. Should we advise to discontinue both of these drugs immediately and cancel the infusion? Please think a moment for yourself before I click to the next slide. Critical thresholds of liver test elevations that should trigger immediate discontinuation of the implicated drug are not well established. However, there is agreement that a rise in ALT more than 3 times the upper limit of normal, in combination with a rise in total serum bilirubin more than 2 times the upper limit of normal, should prompt immediate drug discontinuation. In addition to this stopping rule, discontinuation of therapy is also advised in cases of marked ALT elevation, that is more than 5 times the upper limit of normal, for more than 2 weeks in the absence of symptoms, or ALT more than 3 times the upper limit of normal in combination with fatigue, nausea, vomiting, and right upper quadrant pain. Back again to our patient David. His ALT is 4 times the upper limit of normal and total serum bilirubin is normal. There are no symptoms, so you can decide to start the infusion and do an etiology screen. Here is the diagnostic workup for a hepatocellular type of liver injury, as in our patient David. Autoimmune hepatitis should be tested with immunoglobulin G and autoantibodies. Viral hepatitis with serology for hepatitis A, B, C, and E, cytomegalovirus, and Epstein-Barr virus. Drug-induced hepatotoxicity should be tested with thiopurine metabolites. Non-alcoholic fatty liver disease with liver ultrasound and vascular liver disease with Doppler ultrasound. Other diseases that can cause hepatocellular injury include celiac disease, Wilson disease, and alpha-1 antitrypsin deficiency. I would like to dig a bit deeper into two of the possible causes, namely autoimmune hepatitis and thiopurine-induced hepatotoxicity. Patients with IBD have an increased risk to develop autoimmune hepatitis, but the reverse is also true. Patients with autoimmune hepatitis have an increased risk to develop IBD. The histological features on liver biopsy include portal inflammation and interface activity, that is, inflammation in zone 1, as is shown in the figure. Autoimmune hepatitis generally responds well to steroids and thiopurines, but sometimes the first presentation of autoimmune hepatitis is with acute liver failure, requiring high urgency liver transplantation. This is out of the scope of my presentation, as the patients with conditions depicted on the right side of this picture will have overt symptoms. And then on thiopurine-induced hepatotoxicity. Azathioprine and 6-mercaptopurine, 6-MP, are prodrugs. Only after transformation into 6-TGN, the drug becomes effective in T lymphocytes. In all patients, a proportion of 6-MP is metabolized into 6-MMP. Approximately 10 to 20% of the patients has thiopurine hypermethylation, which leads to higher levels of 6-MMP, causing hepatotoxicity, and lower levels of 6-TGN. This problem may resolve when the thiopurine is reduced to 25 to 33% of the original dose and allopurinol co-administration is initiated. So in patients on a thiopurine who show signs of hepatocellular damage, thiopurine metabolites 6-TGN and 6-MMP should be measured. Here is what we found during the diagnostic workup for hepatocellular liver injury in David. Immunoglobulin G was 25 grams per liter, which is increased, and anti-nuclear antibodies were positive. Serology was negative. There were no normal levels of thiopurine metabolites. Liver ultrasound was normal, and there were no signs of celiac disease, Wilson disease, nor alpha-1 antitrypsin deficiency. The findings are suggestive for autoimmune hepatitis, but can also fit infliximab-associated liver injury. How can we distinguish between autoimmune hepatitis and infliximab-associated liver injury? Think for a moment. We planned a liver biopsy, but on admission for this procedure, we found that the gamma GT was moderately elevated. We therefore also performed an MRCP to evaluate primary sclerosing cholangitis. Patients with IBD have an increased risk to develop primary sclerosing cholangitis. And again, the reverse is also true. Patients with PSC have an increased risk to develop IBD. Patients with primary sclerosing cholangitis frequently have unique distribution of inflammation on colonoscopy, pancolitis, rectal sparing, and backwash ileitis. Some experts say that PSC IBD is the third phenotype of IBD after ulcerative colitis and Crohn's disease. MRCP in PSC patients will show multifocal bile duct strictures and dilatations, as is shown on this picture. A considerable proportion of the patients with PSC IBD will develop complications prior to transfer to adult-oriented care and should be adequately counseled for that. Back to our patient David again. The MRCP did not show any abnormalities. Histopathological evaluation revealed an atypical distribution of inflammation. We discussed whether to start steroids or to withdraw infliximab first. But as David did not show symptoms of overt liver disease, a trial of infliximab withdrawal without introducing steroids was deemed acceptable. What happened after infliximab withdrawal? Eventually, the liver blood tests normalized. Infliximab was not reintroduced. Crohn's disease is now treated with ustekinumab. The safety of introducing an alternate anti-TNF agent is unclear and can therefore not be recommended at this time. I have come to the last part of my presentation. I would like to highlight 4 key points of this talk. 1. ALT, gamma-GT and bilirubin, both total and conjugated, should be determined in the treatment-naive child with suspected IBD and then repeatedly throughout the follow-up. 2. Patients with IBD have an almost 10% risk to develop immune-related liver disease, including primary sclerosing cholangitis, autoimmune hepatitis, or autoimmune sclerosing cholangitis, also known as overlap syndrome. 3. Most agents used for the treatment of IBD have the potential to cause drug-induced liver injury. 4. Moderate to marked liver test elevations should trigger immediate investigations of the etiology. I would like to end with a graphical presentation of the stepwise approach for investigating liver test elevations in IBD. When you are confronted with a child with an abnormal liver test, first grade the severity of the elevation. If the elevation is mild, remember my most important slide, then it is acceptable to retest after 1 month. If the mild abnormality persists, you better proceed to the next step. If the elevation is classified as moderate to severe, then first evaluate if the enzyme pattern and latency fit a typical drug signature. If they do, stop the implicated drug and proceed with an etiology screen. If you cannot relate the liver test abnormality with an IBD drug, then go straight to the diagnostic workup as explained in this presentation. Thank you for your attention. Please inform the Congress participants about the IBD course in general and about this presentation in particular using this hashtag. And in case you want to contact me by mail, here's the address. Enjoy the rest of the Congress.